Hi, everybody. We are going to give it just another minute or two here. It'll let people trickle in, and then we'll get started. All right, it looks like we've got a pretty full house today, which is great. So, hi everybody, my name's Levi Dansinger. So I'm taking part in place of Thomas today, who's not able to make it. I am working with HiPAM as a data scientist to help model and project COVID for the state of Hawaii. So I'm going to be walking you through today's presentation. And do we have the slides live?
Yes, they should be on the HiPAM website.
Oh, and I'm sharing them. Okay, just 1 second, everybody. All right, thanks for bearing with me, everybody. Sorry about that. I'm glad I'm going to be the one driving today. For the week of March 4th, we're going to go over the traditional overview here. We talk about the national overview, dive into the state specifically, go over how we're doing from a COVID standpoint in Hawaii here, and look into some of the science pieces that we want to highlight that are relevant to the current COVID situation. So starting out, looking at Japan, we're seeing a similar trend in Japan as we are in the States. So they are on that downward trajectory, which is great. This has been continuing for several days, hoping that this continues on into the future. Curves are looking really similar to the States, and this is great again because they are such a relevant travel partner for the state of Hawaii. So we do have a lot of visitors coming in from Japan. And again, this carries over when we're looking at it at the United States. And by no means are we out of the woods yet in any stretch of the imagination, but we are on a downward trajectory. So we were putting around 60,000 cases per day here, down 20% when we're looking at it from a 7-day average standpoint. The one thing to note, though, is when we're looking at the graphic on the right, looking at all the coloration here, while we're not seeing a lot of red, the red variants are very extreme when it looks when we compare it to the way that we look at COVID at the state of Hawaii. We typically rank 10 cases per 100,000 as relatively severe, and we would label that as red. So if we did it that way, this would be a much more bleaker outlook. So just wanted to kind of give that as a little bit of a texture here to say that it does look like it's diminishing, but it's still relatively severe when we're looking at it at a per 100,000 people basis. Something that we're also tracking is the variants that are popping up. The numbers are still relatively low, but we're looking at the variants from the UK, from South Africa, and then from Brazil, respectively. I think the most concerning piece here is that one of the states with the most variants is California, which we do have a really high visitor count from. So something that we're going to keep into consideration here. The variant that has the worst outcome from a studied standpoint is the South African variant, which doesn't have quite as many cases so far. The new variant from Brazil, there is a lot less known, but the South African variant is said to be more transmissible, so we are going to keep a close eye on that here in the state. So looking at, again, some of our states where we get a lot of visitors, Arizona and California, both seeing pretty sharp downward trajectories of around 40%, and especially relevant to California here. I think the most concerning piece is when we're looking at Texas. Texas is going down, although they did just release that they are completely opened up. No mask mandates anymore. They're still are independent stores that are doing what they can, but you know, from a policy standpoint, it's pretty much anything goes at this point. So I wouldn't anticipate this to continue to be a negative number. I would expect this to be growing here pretty shortly. So something that we're definitely going to be keeping watch of in the future, as we're likely going to see another spike in cases for Texas. So when we're looking at Hawaii specifically, when Oahu has actually been trending very positively, in the sense that we have a really relatively low cases per 100,000 and positivity rate. Maui is still a place of concern. We are seeing a downward trajectory here, and Maui is what is driving up the total numbers. But for the most part, the other counties are doing extremely well at the current state, and we're hoping that it's going to continue this way in the future. And from a vaccine standpoint, we're still in phase 1B, which means that we are vaccinating the kapuna over 75, as well as the frontline workers. So we are seeing about a little over 15% of people have received their first dose. Over 10% have received 2 doses. So close to 400,000 doses administered, which is really exciting. It groups us about middle of the pack in terms of the rest of the states, in terms of the vaccine distribution. And the good news is that we are also receiving additional vaccine shipments as well. So we have over 500,000 ordered and have received 470,000. So we have, you know, close to 100,000 doses of vaccine that are ready to be deployed. So this is great news, because there's been quite a bit of lag in our ability to get vaccines in the past. So it seems like we're finally kind of to the point where we're catching up and maybe even exceeding that a little bit, which is really exciting. So all the counties are doing well, with Kauai in particular seeing over 20% of people with at least 1 dose. As far as the turnaround time for testing, this has been really consistent over the past few months, really. We're still seeing around 85%, 85 to 90% of tests turned around in 1 day. I don't anticipate this to be a particularly relevant metric in the near future, because we have gotten this process so streamlined over the coming months. If you look at the distribution of the days for November 15th versus now, it's really evened out, especially over the last several months here. So hoping that as we continue along the path here, we're going to keep seeing a majority of tests turned around in 1 day. Now, when we're looking at the forecast for the state of Hawaii, the good news is, again, that we are seeing a downward trend in the 7-day average total cases in the upper left. So, you know, in the beginning of January, we were still in triple digits, and now we're less than half of that. The one thing to note is, as we're thinking about this, the number of cases are, given that they're so low, hospitalizations and ICUs are going to be particularly difficult to forecast, and especially deaths as well. we're going to need to really take this into consideration moving forward. So when you're looking at these forecasts, know that the ICUs and deaths in particular are going to be a little bit more of guesswork, given the case counts are so low. Because if it tracks in certain older parts of the population or the opposite, we're going to see pretty dramatic differences in the ICUs and deaths because it's going to be single-digit numbers here. So just wanted to point that out. We are overall anticipating to trend relatively flat to maybe slightly down. Again, this could change, but this is where we're headed, at least based on the last couple of weeks. So again, this is just representing the graphs just a little bit more numerically. So again, everything's relatively flat, if not down, especially when we're looking at the cases for our expected scenario in the blue, down around 20% in the next 2 weeks or so. Again, this could change given the numbers are so small and the trends are going to oscillate a little bit. But really, the thing to note here is that everything is going to be kind of fluttering around the flat numbers for each of these metrics here. So now we're going to get into a couple of the science articles that we wanted to highlight that we think are particularly relevant. A new at-home antigen test, some great news for vaccinations in the state of Hawaii, as well as a really exciting journal article and study that was written about the effectiveness of vaccinations. So talking first about the new at-home antigen test. So this is the third approved antigen test, and it's going to have really similar sensitivity, specificity as the other tests. It's going to be also requiring a prescription. So it's just another kind of tool in the toolkit for us to be able to understand and track COVID and get a handle on the situation. But it is another tool in the toolkit, and there's a lot of tools out there. So I think that's why we highlight this article here about how we want Hawaii wants to give away COVID tests, but not for the big island airport screening. So there is some confusion around what is going to be relevant for certain metrics that the government or the states are requiring at a given time for certain things. So we need to understand, which tests are going to be approved for a given situation. So this is great that we can get more tests out there, but we have to keep in mind for what purposes are they going to be used for in the future. So coming back to vaccine distribution, so we are going to start moving to include 70 plus. As a reminder, we're currently at 75 plus for the state. So it's actually a week sooner than anticipated, which is really exciting. This is coming from the fact that we did get several extra vaccine shipments, and a lot of this is driven from the new J&J vaccine that's on the market. So we already have 12,000 of these doses, and as a reminder, this is just a single dose vaccine, so it's going to really allow us to move through people to get more people vaccinated. So we're prepping to vaccinate over 1,300 more at the Pier 2 vaccination center. And again, this is really great news because for several weeks, we've had issues with being able to take new appointments due to limited supply. So now we have, we're actually oversupply, so we can start ramping up being able to give people doses, which we're really excited about. So a nod to a really great study that was done in Israel that showcases the effectiveness of the vaccines. So this is a huge study as well. It's not just a study of 1,000 people. It's over 1.2 million. So they actually paired the groups about half and half, around 600,000 in each group, some vaccinated and some not. And they looked at the period of time from 14 to 20 days after the first dose, as well as 7 more days after the second dose. And what we're seeing is that between the 14 and 20 days after the first dose, the vaccine demonstrated around 50%, a little bit lower than that, efficacy in terms of preventing general symptoms, preventing more severe symptoms. But it was really when the second dose was delivered and 7 days after that. For those metrics, the vaccines proved to be about 90% effective. This also includes 90% effective in preventing deaths as well. So overall, it's really hugely impactful, especially when we're looking at these two dose regimen here. We can generally feel pretty good about the efficacy of these vaccines, and to have such a reputable study and such a large sample size, I think it's something that we can be really excited about. So before we move on, I think, in the past couple months, that we've had a lot to be thinking about, and it's been a really difficult time. And again, we're not out of the woods yet by any means, but it's, at least to me, who's really been in it here, it's really exciting to see some movement in a positive direction from the vaccinations, from seeing case counts dropping in a lot of the states, including Hawaii. That to me, I'm really thankful for. So it's nice to see, hopefully, that we're taking a bit of a turn, and not to say that we can drop our guard by any means. Now is our time to be extra diligent to make sure that we really keep it at bay, and allow the vaccines to really ramp up. But I'm excited to share all of this with you guys. So, is there any questions for this section before we move on to to our next guest speakers? Let's see. Nicole, you asked, are there variants in Texas, and do you know how many cases? I believe, again, it's pretty low, even just looking at this graph from the CDC here. So this is just looking at the B117 variant, which is coming from the UK. So it looks like it's around 100 to 200 cases in Texas alone. But given that the total number of cases reported in the US are so small for the other variants, we're kind of assuming that we're not going to be able to track these really effectively yet. So it is small, something to keep in track of for sure. How much worse these variants are going to be is still a little bit yet to be determined. Where in some regard they're seen as worse, especially the B1351 variant. But we'll keep tracking this, and especially if this continues to grow at an exponential rate in Texas or elsewhere. And which vaccine was used in the NEMJ study? I'm gonna look that up and respond in the chat. I can't remember off the top of my head, but I'll make sure to get that answered. And for Lee, what is the full genome sequencing turnaround time? That I'm not sure. I think someone else might be more equipped to answer that question. I do not know. Does anyone else know that can either post in the chat or raise a hand? We can table that for now, just to make sure that we have enough time for the guest speakers. So I would like to invite those who are up next on the agenda to come share with us.
Trey is supposed to share a video first before that presentation.
Okay. Hi, everyone. So I'm going to share a video just to preface it a little bit, so you can be expecting what you see. The information maybe is coming a little fast. What is the video going to get into? So two main points that are discussed are the vaccines and the idea of the strategy of the one round of the vaccine versus the 2 round. Is it better to give more people a single shot, or to give less people the full immunization with the 2 shots? And keep in mind, this is thinking of the 2 shots from Pfizer or Moderna, where we're not thinking maybe now we have some vaccines where the design is just a single round. But for the vaccines where 2 rounds is the full plan, how do those 2 strategies compare? And you'll see that seems like from the analysis done here that the flattening of the curve is much more substantial when we do fewer people, but with both doses to fully vaccinate them. So that will be one part focused on in the video, and also the newer strains that's touched on in the second half of the video. How might the new strains be different? How would that affect the population? How specific to Hawaii might that influence the policies and the strategies? Of course, the early detection you're going to see is the main thing to alleviate the concern for the variants of the virus. And yeah, so that's pretty much the content. Did I miss anything, Dr. Shiba? Could I go ahead and share? Is there anything else I should say to preface the
No,
video?
go ahead and share so they have time to do the other presentation after. Thanks.
Okay, I'm gonna try to share. Can you guys see my YouTube?
Yes. There is no audio. Do you have your cast?
Sorry, everyone. I could hear the audio, but let's see. Share sound. Sorry about that. Let's try that one more time. When someone shout me down if the audio is not working.
The emergence of the COVID-19 pandemic has created unprecedented public health challenges and spurred a global race to develop and distribute one or more viable vaccines. As of February 19, 59.59 million vaccine doses have been administered in the United States. 17.04 million people in the United States have received 2 doses or are fully vaccinated. In Hawaii, as of February 21, 249.4 thousand doses of vaccines have been administered. As of now, 2 vaccines are authorized and recommended in the United States: Pfizer-BioNTech and Moderna's COVID vaccines. These vaccines help our bodies develop immunity to the virus that causes COVID-19 without us having to get the illness. These vaccines are tested, FDA approved under emergency authorized use, safe and proven to control the COVID-19 pandemic. Common side effects include fever or headaches and typically last between 24 to 72 hours post-vaccination. 2 side effects in particular, body aches and chills, may even indicate that your immune system is responding to the vaccination. There are several questions on how different groups will be prioritized and equitable distribution of the vaccine be ensured. According to Hawaii's vaccination plan submitted to CDC, here is a distribution plan that can help you find where you are in the vaccination timeline. The initial vaccine studies did not include enough numbers of children below 16 years, so it is not recommended for them at this time. As of February 21st, Hawaii has a limited supply of vaccines, prioritizing high-risk priority groups. To protect as many people as possible, many countries, including the UK, have recently announced to prioritize giving only 1 dose of corona vaccine to as many individuals as possible, instead of giving 2 doses of vaccine to each individual. This strategy, however, might not be effective to reduce COVID cases in the state of Hawaii. Here are some simulations with different scenarios in Honolulu County. The red line here assumes vaccination of slightly under 350,000 individuals in Phase 1A, 1B, and 1C with 1 dose of vaccine. The green line assumes a 50% level of vaccination compared to 1 dose, but with each individual receiving 2 doses. and the orange line assumes the same level of vaccination than for 2 doses, but assuming only 1 dose was administered. As we can see, the gain produced by vaccinating twice as many individuals with only 1 dose would not flatten the curve significantly. So due to uncertainties related to the 1 dose efficacy and length of protection, these simulations suggest that at this time, distributing 2 doses is a better strategy for the state of Hawaii. Multiple new strains of the virus that causes COVID-19 have been documented around the world, and some suggested to spread more easily and quickly than the original virus. Cases of the new strain B.1.1.7 have been seen in our islands. Containing the impact of this new strain is vital. Our simulations analyze whether these vaccines can be effective to control new strains of COVID-19. We compare several scenarios. Here you see the daily cases assuming an introduction of 20 individuals with a strain 50% more transmissible, and for which vaccines have the same efficacy. The second plot shows the result for a higher vaccination rate. Now we compare our original scenario to ones with a higher number of individuals with the more transmissible rate. It shows that an initial number of 50 individuals with the new strain is more impactful than influx of 120 individuals spread out weekly. It shows that early detection is key. Although it isn't proved if the vaccine works as well to control the new strains, the simulation shows that more fully vaccinated people can be crucial to control not just COVID-19, but also the new strains of COVID-19. As of now, rapid distribution of full vaccine doses with strict implementation of mitigation measures is the only way to end this pandemic. Do not hesitate to get vaccinated as soon as it is available to you. Even if you have already recovered from COVID, according to experts, you should still get your vaccine. And even if you already got vaccinated, you still need to wear a mask and follow other mitigation measures. Let us all be more vigilant, protect and educate ourselves and others, contribute to slow the spread of COVID-19, and ultimately end it.
Thank you, Trey. I think we can move to the next presentation. Alan, I think you're going to share your screen.
Yes, I will do that. Okay, I think it looks good. Hi, everyone. My name is Alan, and presenting with me is Pratik. I'm an undergraduate studying mathematics at UH, and Pratik is a grad student also doing mathematics at UH. And we're talking about COVID and the counties of Hawaii. We're interested in seeing how pandemics spread in island archipelagos, especially because Hawaii is particularly vulnerable to pandemics. Studies have been done on heterogeneity in other types of locations, such as cities of China, as seen in the below paper, but not yet on an island chain. Since we're the primary victims of our own islands, we think we're the best ones to talk about it. And to start off, here are some of Hawaii's statistics, which will help us understand the unique characteristics of each county/island. Some things are expected and obvious, but not so obvious is the tourist amount, which shows the ratio of tourists compared to residents. So Honolulu has the least and Kauai has the most. A large challenge for the study is data access. Sometimes a certain statistic we're interested in can't be found, or it's hidden away and can't be downloaded. Fortunately, the Department of Health and other services provide COVID-19 dashboards to the public. And when we were beginning our research, we had many options for our data from the Department of Health or from the Hawaii Emergency Management Agency or others. We chose to stick with the Department of Health and with the Hawaii Data Collaborative. The Hawaii Data Collaborative gathers their data from the Department of Health and makes it into a daily updated Google Sheet, which we can download as a CSV. And that way our data comes from one source and is easy to work with.
Now that we've looked at the materials and method, let's talk about the model that we use. SEER models have been used to model infectious diseases for a long time now. For our purpose of modeling the spread of COVID-19, we used a discrete and deterministic SEER model. The dynamics of the susceptible population are governed by the hazard rate lambda t. We use this to determine 1 minus e to the power negative lambda, which is the probability of an individual being exposed at time t. Exposed individuals go through 14 discrete stages of exposure, where the probability of moving from one stage to another is adjusted so that 40% of the exposed population remain asymptomatic. Once infected, there are 5 stages of infection, each of which may last for more than 1 day. The last stage is removed, which consists of individuals who remain asymptomatic for 14 days or go through the infectious stages of the disease. The entire population is divided into 3 groups: community, healthcare workers, and travelers. Each of these groups have the 4 aforementioned compartments. The travelers come into our model from October 15, which is when the Safe Travels program was initiated. The travelers are further broken down into returning residents and tourists. While returning residents are absorbed into the community bucket, tourists are considered separately because of their distinct behavior from the other categories. We will see that the behavior of the Hawaiian counties begin diverging with the introduction of travelers. Henceforth, we will use the term traveler and tourist to mean the same thing. The complications of the model require us to make various assumptions, which we can classify into 2 major categories: geographically dependent and virus-dependent factors. Some examples of virus-dependent factors include asymptomatic transmission rate or probability of onset of symptoms, etc. Whereas geographically dependent factors include mask compliance, asymptomatic quarantine, which we use to model contact tracing. The values for these parameters were carefully chosen to model the specific situation. Once these parameter values are fixed, beta, the transmission rate for the disease, is optimized to reflect various events and policy changes that affect the behavior of the population over the time period. So using the model and the assumptions described, we obtain a fit for Honolulu County with optimized beta values. Here, you can see the orange dots. They represent the actual new infections per day, and the red line is the simulated number of new infections. The step function in the background shows the values of beta over the span of the simulation. The vertical lines are labeled with dates and significant events on those days. They correspond to policy changes like imposition of lockdown or beginning of safe travel program, etc. One thing you can notice here is that similar levels of beta in summer gave a much larger spike as compared to the period after that. This is due to the effect of contact tracing and increased mask compliance in the later period. From November 24, travelers were required to have a negative result before departure, and this caused a decrease in the average travelers per day from 4724 to about 2195. And this effect can be seen in the form of a dip in the curve. The beta values have been optimized with the events that are happening on Honolulu County. Here is the fit for Maui County, optimized with the beta values. An exponential increase can be seen at the start of the Safe Travel program, which was October 15. And this is in spite of an observed 95% testing among travelers to Maui as compared to 86% for the other counties. The influx of travelers is not constant through time, and it varies from 800 per day to a peak of 3,000 per day. Since the ratio of tourists versus residents is high on Maui, we see as a result a wavy increasing curve. In addition to the effect of tourists, must be pointed out that there was a large outbreak in a relatively high population density condominium complex. The initial increase after October 15 was solely due to travelers, which is why we see a rise in daily cases, even though the basal transmission rate beta remains relatively small. This is the fit for Hawaii County with optimized beta values. The data for Hawaii County can be seen to be noisy, particularly after October 15. There is a puzzling decrease in the number of cases after the start of the Safe Travel program. And this can be explained by the spike right before that being attributed to an isolated cluster event, which is unrelated to any other activity in the county. One thing to note here is that in comparison to other counties, the average number of travelers in Hawaii County is low, starting around 297 per day and reaching a peak of 1,712 per day for 2 weeks before subsiding down to 1,000 per day. Also, since November 24, travelers were required to have a negative test before departure, and we model this by a slight increase in testing rate for the travelers from 86% to 90%. Since the number of daily cases for Kauai County were so low, beta values could not be optimized and any kind of fitting was not possible. Hence, we show here the actual number of cases as orange dots and the 7-day average as a red line. We can observe that there was a spike right after the start of the Safe Travels program. No deeper analysis was done for Kauai County. Here we have the 4 counties in the same place, so you can take a look at it. They include simulated values for the 3 counties of Honolulu, Maui, and Hawaii, and the actual daily cases for Kauai. One thing to notice here is that there is a distinct behavior post-October 15. These plots show the actual daily numbers, and because the daily numbers are vastly different in each of the counties, a better picture can be presented by normalizing the daily cases by the maximum value and then observing the trends in them, which we do in the next slide. Here is a comparison of the 4 counties. For Honolulu, Maui, and Hawaii County, we use the normalized values of the simulated daily case, whereas for Kauai County, we use the normalized 7-day average. We notice that post-October 15, there's a significant divergence in the behavior. To capture this dissimilarity, we use the L2 distance, which is calculated as the square root of the sum of square differences between the daily cases. And we did this for 2 time periods, March 6 to October 15 and March 6 to January 15, in order to capture the dissimilarity that comes into play after October 15. Now for each pair, notice that the L2 distance increases when the time period since the beginning of Safe Travels program is included. And this increase, especially if you look at Honolulu Maui pair, which is more than 200% increase, is much bigger, even though the addition of the time period is not as much. And this clearly shows that there is a divergence in the course of the pandemic for the 4 counties post the Safe Travels program.
Heterogeneity in each county's strategies has already been initiated to some degree, with Kauai County implementing their more restricted travel policy on December 2nd. On January 19th, Maui implemented the mandatory safe travel apps for all travelers. Kauai is looking at resuming the safe travel program in April. And despite having similar travel measures, Honolulu and Maui, for instance, display a different spread as according to Pratik's distance table. There's a need to look further at the differences between the islands. After creating fits for each county, we were interested in seeing if we could make some connections to the daily cases. One of the ways we did this was by plotting the daily cases, positivity, and test on one chart. These three statistics are different in nature, so to compare them, we compare them qualitatively. We do this by normalizing them each by their max. And we also examine the mobility index provided by the Department of Health, which is a measure of anonymous resident movement. In terms of Honolulu County, we see that in July, the positivity rate increases alongside with daily cases, indicating an outbreak. In December, we see the positivity rate rising with testing falling, which predicts a rise in cases. In terms of the mobility plot, there's no outlying feature other than a slight correlation with the cases. When we repeat the graphing for Maui, we obtain these plots. We can see an initial spike in positivity, and further down the line, more spikes alongside with the daily cases. These correspond to outbreaks in Maui. In December, we see testing drop as positivity increases, again indicating a rise in daily cases. Mobility here also makes no mention aside from a daily correlation. We repeat the plot with Hawaii County, noting the early positivity spike. This spike is an indication of the first outbreak. And we also see that testing becomes steady immediately, and the positivity rate drops, indicating a slowdown of the virus in daily cases. We again see no significant feature of mobility, but acknowledge that it still correlates okay with the cases. Doing the plot to Kauai shows a few more interesting things. Despite the really low counts, and daily cases and positivity still line up pretty well. And we also see that the daily case spikes also occur as a result of the total test decreasing as positivity increases. Mobility actually does not correlate with daily cases, differentiating itself from the past three counties. And this is because Kauai had the more restrictive travel policy. It became more of a bubble, and mobility didn't matter necessarily as much because travelers weren't coming in as much. Looking locally, we also gathered daily cases of spatial data organized by zip code. The only note of this data is that if cases are less than 10, then the Department of Health does not report it, specifically for security and privacy reasons. So most of Kauai is missing since we don't have anything really there. Looking first at Honolulu, we see two major regions sticking out. Aiea sticks out so far that we had to plot it separately on the daily curve from the rest on the bottom left. From this, we can see spike behavior, which we actually can correlate to outbreaks in Halawa Correctional Facility. The second major region is Waianae, and we know that Pacific Islanders are being disproportionately affected by COVID-19, which is reflected in their higher density in Waianae. Looking at Maui, we can see a couple of spikes around the west. One in particular we attribute to an outbreak in a multi-story, while two of the other regions have a much higher tourism ratio. Looking at Hawaii, we see two major spikes. Not coincidentally, these two are the locations of Hilo Airport and Kona Airport.
Comparing the counties to each other led us to see if we could compare the Hawaiian counties to other island regions. Next, Alan. Thanks. We wanted to see if similar mitigation measures were used in other regions and how it impacted the daily case numbers. For that, we chose Iceland, Puerto Rico, and Japan. And then we used the L2 distance, which was described before, to measure the similarity between all possible pairs. However, we were not able to draw meaningful conclusion from it. And this is primarily because the timeline of the pandemic is not the same for each region. Instead, we analyzed the similarity by looking at the qualitative structure of the results as captured by merged trees, which we describe in the next slide. Let's take the Honolulu fit for an example and see how a merge tree can be created. For the purpose of this analysis, we are only considering the time period between June 15, 2020, January 15, 2021. We do this in order to account for a non-uniform response between the various regions at the start of the pandemic. Everybody was what to do. A merge tree is a tree structure that captures how valleys are connected to ridges or how local minimas are connected through local maximas. So we begin by identifying the minimas, which we show with red dots here. Then we identify the local maximas through which they connect. And by keeping track of how these connected components merge, we obtain this merge tree shown on the right. You can take a few seconds and look at how this merge tree was constructed from the plot. Some information that this gives us, for example, is that it tells us there was a large peak followed by a minor peak later on. With that, we constructed the merge tree for the corresponding regions, and they are shown here. These were computed using the normalized time series for the daily cases starting from June 15. We also simplified the structure by removing very small branches. We can see here that the Honolulu County merge tree is most similar to the Iceland merge tree, and the Maui County merge tree is most similar to the Japan merge tree. The complexity of the Hawaii County merge tree makes it more similar to the Puerto Rico merge tree, but these two are not good of a match as the other pairs. And this comparison is favored to the L2 distance because it is invariant to time shifts, stretches, and time shrinks. And one way to read these graphs, you can go from left to right temporarily. And they are conceptual abstractions of the epigraph. As mentioned before, they give us a picture of how valleys and ridges in the graph are connected to each other. For example, if you look at the bottom left, the merge tree for Hawaii County, you can see that there are two peaks relatively close to each other and some minor peaks which occur later on. Whereas for Puerto Rico, there are minor peaks in the beginning and a large peak that occurs towards the end.
To summarize our presentation, we explored the importance of taking into account local variations in the islands. Ratios between residents and tourists, as well as age demographics and other specificities, call for targeted mitigation measures and safe travel programs when in a pandemic. The state of Hawaii has launched an aggressive mass vaccination campaign in December, but the effects of which are only now impacting the daily case rate. During the period of our study, the very small impact of vaccinations were neglected. Not studied in this is hospital beds capacity for the state of Hawaii. The primary reason we did not discuss this is the lack of consistent and clear data regarding hospitalizations. A large concern is that Honolulu epidemic cases mostly dominated the state count for a while, which we should not use to induce statewide orders that incorrectly apply to other counties. Thank you. I guess we should allow for questions.
Is there any questions from the group? I didn't see any pop up in chat or in the Q&A. Okay, it doesn't, oh,
Um, so Mark, I am not sure about that. I don't think I'm the one that should be answering that. We can only give recommendations, but from what uh, Trey Richard presented, I believe it should be 2 shots. And Jim, I'm not sure about that either. But if anyone else would like to chime in.
Well, if I can just take a stab at that. So Mark, your question is interesting because the one-shot Johnson and Johnson vaccine was approved. And at the time, as of now, we haven't used that in the simulation at this stage. But what it suggests is that we need as many people as possible to be vaccinated. So it just means that we will be giving one shot, if this is what you refer to the Johnson and Johnson, or 2 shots with the Pfizer and Moderna. If your question is about when a vaccine requires 2 shots, should we go and give just 1 shot to vaccinate as many as possible? It seems that then if 2 shots are required, at least for Hawaii at this stage, we should stick with 2 shots, especially now that the Johnson and Johnson is coming to add and has the 1-shot capability. Jim, I don't know. We're just mathematician. I have no idea how to reach legislator or anything.
I have one quick kind of technical question. I just had a curiosity, those merge trees, is that more of kind of an exercise in curiosity, or do you feel like there's a lot to be drawn from that? I know it kind of seemed like there's kind of some loose conclusions, but like how seriously are you guys kind of looking at those trees as some kind of indicator?
No, yeah, go ahead.
So yeah, we basically used that so the thing was we wanted to compare the different regions, and using L2 distance is not very good because the pandemic time, there's a lot of different things happening at different time, not the same for the different regions. So we wanted to remove all of those parameters or variables and just look at the qualitative structure of it.
I think, yeah, if I can add, I think, Levi, that there is a lot of potential to that. I have not read about that before, and so it's just something that we came up because we didn't have a proper metric to measure. We don't have even a proper definition of a wave exactly. When do you consider that a wave is done and then you pass to the second one? So we talk about peaks. So I think there is a lot that needs to be done in terms of qualitative assessment of that sort and not necessarily quantitative.
Yeah, thanks. Super interesting.
Maybe Pratik, you can answer Yoshi. He's asking how the hazard function was determined.
So the beta values were basically determined by the events that were happening or legislative changes. And so they sort of keep track of the things that are going on and which affect, let's say, if we have a lockdown or if a lockdown is removed and what kind of behavioral changes those are going to present.
Yoshi, we can give you, we have a paper that uh, uh, that shows everything. So we can share with you without a problem. Oh, I think your question is, okay, so you mean like when you have mitigations? So at first, at the beginning, you don't know the RT value or our beta value, right? So now that we've been able to look at the past in order to fit the value, then you have to optimize with a certain beta. So it gives you, depending on the condition, the mask mandate, whether it was on a lockdown, etc., what type of beta value you have to take into account. So it's for the forecasting, is the past is going to tell you how to move forward in the forecasting. But at the beginning of a pandemic, you don't know. And then Jim, you asked the question about a civil bid article. Yeah, again, I'm not sure exactly how those things work. Last time I was invited, so that's why I wrote one, but I don't think that you force, I don't know how it works, so honestly. Yeah, it would be great to write another civil bid if people are interested in hearing that kind of study as well, comparisons.
Any last questions from the group? Okay, I think we're going to close out the meeting today. So thank you so much, Pratik, Alan, Dr. Chiba, for all that wonderful information. I really appreciate how dynamic and thorough the approach to your inputs and to the modeling. And I think it's so complementary to all the modeling that we've done on our side, and really expanding in a way that we haven't been able to. So just really grateful for that. So thank you guys so much for sharing. And really appreciate you guys all for coming to the meeting today and attending. So thanks for taking time on your Thursday evening, and I hope we'll see you guys all next week. So have a great day.